So thank you, everyone, for a great morning of discussion. Let's keep it going this afternoon. We're going to go on and start by talking about lower respiratory cultures. And Tim Block and Tyler Radke are going to be presenting this section. So they will be leading, and hopefully you'll participate and help them continue the great discussion.
All right. Welcome back after lunch. Tim and I will be presenting on lower respiratory cultures, what we, view as some best practices. I do want to call out, as you'll see, laboratory manager. This is relevant because you're getting a presentation from two people that really don't work microbiology very much anymore, so this should be interesting related to best practices. I'm just prefacing our presentation with that. Anyways, moving on. So some objectives for today, introducing common lower respiratory tract diseases, briefly review some specimen collection, discussing process and importance of the Gram stain, reviewing some culture workups, discussing some of those less frequently encountered organisms, and assuming there's time, because we're planning to have time, discussing new and emerging diagnostics in special circumstances. So this is a relatively lengthy presentation, so we might skim through some of the slides as we go, but starting off here, it's just some lower respiratory tract anatomy, and really kind of focusing here on, starting with the lower respiratory tract, moving down the larynx, down to the trachea, and really going to land on a focus here. And I will say some of this is recycled material from our previous presentation, so thank you for those that contributed back then, because we're using it again now because it's highly relevant. So anyways, looking back here, we'll be focusing obviously with lower respiratory tract on the lung and lower lobes, upper lobes, but really then getting down into some of the bronchioli and alveoli. So some of the diseases worth noting, acute bronchitis, bronchiolitis, acute pneumonia being one of the more focus points today, and chronic pneumonia. And listed there some of the very common etiologies that you can expect. Notice viral is at the top. It is one of the most common etiologies associated with diseases of the lower respiratory tract. And then some of your pneumonias that are present with pneumonia, but also present in blood culture. Since it was highlighted earlier, Klebsiella pneumoniae in a blood culture, the patient did not have signs of pneumonia present. It was a great little anecdote there. So acute bronchitis, starting here, some of the things worth noting, it is a self-limiting syndrome. I love the picture that's up here, just comparing the normal bronchi versus what it looks like for bronchitis there. And again, very common causes being viruses listed there. And overall, really less than 10% are caused by bacteria, with some of that bacteria being things we're not routinely going to pick up in a lower respiratory tract culture. And maybe that plays into some of the diagnostic testing, maybe later on in the presentation, or just in this space in general. And some of the signs and symptoms, I'm not going to hit on all this as we go through, but worth noting. Bronchiolitis, so if I go back, I think D was back here. And again, looking at the anatomy here, we're kind of just moving down, right? So going from the bronchi there down to bronchiolitis and where that can be found. Again, a very common viral lower respiratory tract disease, most commonly in the first 2 years of life. So you're thinking of small children, pediatrics, RSV, which we had a fairly active RSV season this year, so I'm sure a lot of us ran into this. Some of the signs and symptoms associated with that and changes that can't be seen, but again, what you see there is some constriction occurring in the bronchial airway there. Did I go backward or forward? C is forward. There we go. Moving on, acute pneumonia. So infection that is now causing inflammation of the alveoli. So really getting down in, again, the deeper part of the lung and seeing some of that infectious process occurring here, what it looks like comparatively to the normal sign there. And signs and symptoms worth noting, the thick blood-tinged or yellow-green sputum, an abnormal chest x-ray being very common. Also worth noting for acute pneumonia, one of the single most common causes of infection-related mortality in the United States. So it is a big issue, which is why we probably have diagnostic testing looking for that. There are many syndromes associated with acute pneumonia. So you have community-acquired pneumonia, hospital-associated pneumonia, healthcare-associated pneumonia, ventilator-associated pneumonia. Somebody help me out here with BAP, bacterial aspiration pneumonia. So there's a number of pneumonias that are notable here that are causing signs and symptoms that all play into the lower respiratory tract disease. And there's chronic pneumonia. So really kind of calling out here again, sputum production, persistent progressive cough, but lasting weeks or months rather than days. And it is always associated with an abnormal chest x-ray. Many different causes, but viral being something that rarely progresses to a chronic pneumonia. So again, as I was trying to remember those acronyms, I do have them at least defined here a little bit better. So the pneumonias and kind of all the overlapping things occurring here. So the community-acquired pneumonia, of which, oh, must have capitalized on me, grammatical. Strep pneumoniae being, strep pneumonia is 60% of the bacterial cases of pneumonia, which may not jive with what you see when you're doing lower respiratory tract cultures, but that'll be covered a little bit as to the why in a little bit further within the presentation. But overall, strep pneumoniae cases are on the decline, and a lot of that being associated with the use of vaccination practices with a 13-valent vaccine. Hospital-acquired pneumonia, so worth defining here, this is occurring 48 hours or more after hospital admission. And with hospital-acquired pneumonia, it's relevant that typically there's resistance to one or more commonly used antimicrobial agents, which is going to contrast a little bit with the community-acquired pneumonia. Healthcare-acquired pneumonia, so what the difference here between hospital-acquired and healthcare-acquired is really, it kind of boils down to it's occurring in a non-hospitalized patient who's had extensive healthcare contact, recent hospitalization, nursing home, time spent in a nursing home back and forth, wound care, et cetera. So that healthcare-acquired really being associated with a lot of contact with healthcare entity. Ventilator-acquired pneumonia, and kind of contrasting that with the hospital-acquired, ventilator-acquired, developing more than 48 to 72 hours after endotracheal intubation. So kind of that being a driving cause, obviously ventilator-acquired, being that ventilation process likely is, contributing factor to the development of that pneumonia. So the frequency of that, a fairly broad range of 9 to 40%. And you generally see an increased prevalence of gram-negative rods with that. Bacterial aspiration pneumonia, this is going to follow aspiration of really upper respiratory tract microbiota that during potentially an aspiration process. So with that, because it is upper respiratory tract, you do also see some involvement of anaerobic bacteria. Okay, so we kind of covered some of the etiology there. Moving into specimen acceptability and what specimens we're looking for. So there is expectorated sputum, induced sputum, and kind of highlighting in here, not induced sputum is generally not routinely used for bacterial culture. Suction sputum, endotracheal aspirates, tracheal aspirates / vented patients. So this is can be clinically misleading because of bronchus colonization. So if you think about going back several slides and the anatomy there and where that vent is landing compared to where the bronchus is, that is where you can get some of that colonization occurring. So those can be tricky cultures to receive and work up. Bronchial washings, bronchoalveolar lavages, and transbronchial biopsy specimens. So there's a number of different specimens that you may receive and can receive, obviously, for lower respiratory tract cultures. So just focusing really here on sputum. The expectorated sputum is really a deep cough sputum. It does not have any rinsing with non-sterile water prior to collection, because you would just be introducing potentially bacteria found in that water. No saliva or post-nasal discharge. So that's relevant, obviously, when you're talking about in expectorated sputum, trying to get that deep cough, making sure they're not just providing spit, saliva, or post-nasal discharge, which can appear like sputum sometimes, but not being fooled by that. That's not a specimen you want sent and worked up for culture. And then really, a trend with a lot of microcultures is having that collected prior to antibiotic therapy whenever possible. Contrasting that with induced sputum, that's really more of a mechanical collected sputum, so it can involve a toothbrush. It does not use toothpaste, but you would see rinsing of the mouth with sterile water in a situation like that. And oftentimes use of an ultrasonic nebulizer. Bronchoscopy samples, again, bronchial wash samples. So highlighting here, from the major bronchi at the bifurcation and right and left bronchi. It is commonly done to diagnose cancer in patients with bronchial lesions or masses. So that's, I guess when you think about when you're getting a specimen like that for culture, it's worth keeping that in mind, that this is more often than not more commonly seen as a specimen submitted in part of the workup when they're looking for cancer. And one other thing worth calling out, wash samples, if you're getting a bronchial wash sample, that actually is indicated to not be pooled. I know there is some conversation, some specimens that we do talk about potentially pooling together through the microculture process, but bronchial wash samples are actually recommended not to be pooled from different lung locations. BALs, that is collected from the distal bronchioles and alveoli. So you're thinking, you're really getting really down far into the lung, and really, wedged is probably a good term used there, because they're getting pretty down deep into the lung to get sampling from the right upper lobe, right middle lobe, left upper lobe, so on and so forth, but getting pretty deep into the lung in this instance. And in this practice, aliquots from the same site may be combined for cultures and smears. But really, the guidance on that is, if you're going to do something like that, that's really something you want to take up with local stakeholders. So infectious disease being a big stakeholder, pulmonary being a big stakeholder, and that have that conversation with them and understand, are they open to us pooling those samples or keeping them separate? Yes. Sure. So this would be routine bacterial cultures. That is also worth having a conversation with ID and pulmonary on getting their input for, fungal and AFB as well. I've heard some different things in conversation with them, and some of it just comes down to provider preference, or even just provider understanding of what you're really asking to be able to do with the specimens when they're down in lab. So transporting and processing, delaying transport and processing, much like a lot of the microcultures that you may perform, there is concern that delay in transporting that specimen to the lab and getting it processed, plated to media, is going to affect fastidious pathogens and obviously potentially inhibit growth. So strep pneumoniae and Haemophilus influenza being the two bigger call-outs of those that could be suppressed if there is a delay in getting those to the lab and plated to media in a timely fashion. Also with processing BAL samples, you may consider doing concentration prior to inoculation and gram stain. A lot of what I'm pulling from here is the ASM Clin Microprocedures Handbook, the most recent edition, and doesn't take a strong stance one way or the other on some of these items. So just worth noting that it is open to how you would like to practice at your institution, and having those conversations and looking at benefits and limitations of any way you would like to do that. So acceptability criteria for sputum. Poorly collected sputum samples are wasteful and can lead to erroneous reporting and treatment. And I think most people that are doing lower respiratory tract cultures are aware of that. As you'll see it does drive some of your work up. But the qualification here being that sputum that's sent for Legionella, nocardia, AFB, or on cystic fibrosis patients, you are still going to proceed with culture or with diagnostic testing if it's not culture on those specimens. But yeah, I mean, really the big thing here, sputum cultures are already an insensitive diagnostic test. So it's not, the acceptability criteria needs to be applied because accepting anything and everything into the lab is going to further dilute out that diagnostic sensitivity and obviously contribute to unnecessary laboratory workup. So, question here for a clicker question. Looking at a sputum submitted for gram stain and the quantity of epithelial cells for rejection. So the question being, what quantity of epithelial cells do you reject? Sorry, please enter your answer again. All right. So a pretty good split between B and C. B being greater than 10 squamous epis and C being greater than 25 squamous epis, which is interesting because I have what I was used to practicing and what the literature listed there below now states are different things. So in the current updated guidelines for quantity, what's recommended for rejection criteria is actually greater than 10 squamous epis per low power field, which contrasted with what again, not practicing micro on a routine basis, but historically what I had been taught and followed was a greater than 25. So that may have been a recent change in the ASM Clin Micro Procedures Handbook. But yes, is there a question? Yes.
So we actually use a scoring criteria. So white cells greater than 20.
Like a Q score or Q probe kind of thing?
Yeah, we're looking at like white cells greater than 25 is 2 points, 10 to 25 is 1 point, presence of mucus is 1 point, and then -1 for epis 10 to 25, and then greater than 25 is -2, and then any positive score is considered acceptable for culture.
Yeah, I believe that's one of the Q score or Q1, 2, 3, 4 scores. That is, I would be curious to see if anybody wants to raise their hand and also acknowledge if you're also using a Q score method for sputum criteria acceptability. I see 1, 2, a couple people. How, in terms of deploying that, was that fairly complicated to learn and teach the team that process?
No, it was just counting. I mean, right in front of their scope is just, here's your score.
Okay.
If it's positive, then you accept it.
So I guess it's maybe analogous to like a Nugent scoring system on a vaginal gram stain then, potentially. Okay. Thank you for that. Yes? I'm sorry if I said mucus present for the. For the Q score. Oh, you said there was for the Q scores, are mucus present?
Yeah, we evaluate on the gram stain. And usually you can see the threads on the gram stain.
Okay.
Please remember to use the microphones because of the recording. It will really help the recording for us. Thank you. No, I can run. That's fine.
I do have a question for you, though. Do you have anything like that in a logarithm built into your LIS that helps with that, or is it all just done manually at the scope to determine whether it's acceptable or not?
Yeah.
Okay.
Okay. Thank you. Yes?
So are you basing your rejection criteria solely on epicells, or if you have 10 epicells and a preponderance of inflammatory cells, does that supersede your 10 epicells? Do inflammatory cells factor into any of this? To be in a nutshell?
I don't believe, that's going to come down to obviously institutional practice, but Tim, do you recall seeing in ASM if they had indication of that?
Honestly, I don't.
I don't
think,
either.
I
I
think
feel
it
like
was
it was
straight up on 10 EPIs.
That's what I thought too. Yeah, I don't recall seeing that in the Clin Procedures Handbook when we were reviewing it. I know historically that has been some of the consideration. If you do see, preponderance of PMNs maybe associated with, a predominant morphotype, that would potentially proceed, but I don't recall seeing that in the current updated guidelines.
You have to think about the garbage in, garbage out principle. So someone may truly have a pneumonia, and let's say it's strep pneumo or H flu, and you're going to have a lot of PMNs, but they may not. They might have, a lot of PMNs for other reasons. But if you've got those squamous epis, you've got those opportunistic pathogens. That's potential is going to give you what I would call a false positive. And I remember a number of years ago, because there was a number of papers that were written sort of like within a 5 or 10 year period about this back in the 80s. And one of them was, he was a clinical microbiologist, Pat Murray. He was a fellow at the time. And I was actually young and get excited about this stuff. And I called him and I talked to him about it because I was curious. And I remember him saying is like, you don't need the WBCs because again, you want to keep the, if there's squam epithelials, it's the same with urine culture. If you've got in there, it's a bad sample. And then so the diagnostic, the predictive value has gone down. They might still have pneumonia, or they might have a UTI. So I think that makes sense that that you don't just go by the squames.
Yeah, I think that's a good point. And to kind of go along with that, when we talk about, and I had showed it in the slide earlier, the diagnostic yield of a lower respiratory tract culture being, fairly variable, but definitely not exceeding 40%. And that's on, specimens that are acceptable for culture. So if you're trying to potentially further widen that net by accepting specimens that have a high epi count, even though they have associated PMNs, you're probably further reducing that sensitivity of that lower respiratory tract culture. Okay, moving on. Moving on to the gram stain setup. So unsurprisingly, you're going to perform the slide prep and fixation in a biological safety cabinet. You don't know what's in that sample, and that's just good microbiological practice. You're targeting the most purulent part of the sputum to make that slide. With a BAL or bronch wash, you're utilizing 5 drops of sample, and you can place that directly into a cytocentrifuge chamber if you happen to utilize that. Ultimately, smear is left to dry, air dry and heat fix in the BSC, the biological safety cabinet. And alternatively, you can air dry and methanol fix for direct specimens instead of doing the heat fix. There's some statements that refer to methanol fixing being a little better for the specimen and retaining some of the elements of that specimen, where you get a little degradation associated with heat fix. And then, you're kind of proceeding forward with staining the slide either manually or with an automated stainer. Automated staining can introduce more stain variation, so I would be curious to see those. Is everybody here using an automated stainer? Is there still a pretty good mix of manual stains occurring on these specimens? I think of a sputum specimen. Let's see if I have that on the next slide here. Yeah, looking at a gram stain assessment. Whether you're doing an automated stain or a manual stain, you're going to still perform this gram stain assessment in the same manner. Whoops. But you would definitely see more variation in automated stain because you're kind of potentially in how you're utilizing it. You might be putting everything in together: wounds, abscesses, sputums, urines. If you do urine gram stains, we do urine gram stains. Because of ICU request. But when you're doing that and you're putting everything into the same staining protocol, you're going to get some variation in the amount of methanol being applied to the stain and decolorizing agent, and how that's working. So overall, when you're looking at your gram stain, you're assessing that gram stain at the 10x objective. And, some of the good indicators that you're looking for, you want to make sure things have appropriately decolorized. So squamous epis, white blood cells, red blood cells, none of those should really be retaining the crystal violet stain. Do we all know why? Everybody knows why, correct? What crystal violet binds to? So if you're using, okay, yes, I don't see anybody nodding their head. Peptidoglycan, yeah, very heavy in the gram-positive organisms, yes, yeah, okay. So that binds stronger to, okay, good. All right, so you're looking for that decolorized, those decolorized elements. So that, oftentimes when you're scanning your gram stain, you're already looking for squamous epis, you're already looking for white cells, or white blood cells, but making sure that they appropriately decolorize so it's not influencing the potential bacteria you have on that slide. Some of the poor indicators, stained precipitate crystals, indicating that it was probably not decolorized enough. And then overly thick layer. So again, if you have different stain protocols, or just a sputum specimen can be very thick, or an abscess specimen for that matter, and making sure your layer isn't too thick so that it does the appropriate staining and decolorization. I like to highlight this with new techs that are working in micro, or those PM and night shift techs that only work in micro when a blood culture goes positive, or they have a stat something or another that needs a gram stain. Looking at the proper elements of gram stain assessment to make sure that their stain slide came out appropriately, because the last thing you want is them calling a gram positive rod when it should have been a gram negative rod. I went backward. Here we go. Gram stain interp. So you're looking at 20 to 40 fields under a 10x objective, determine an area representative of inflammation or purulence. That's where your focus point should really be. And averaging the number of cells in representative fields that contain cells. So, you're not looking at the empty part of the slide and using that as part of your 20 to 40 fields. And then again, rejecting specimens is what guidance says, and I know there's a lot of variation. I don't believe that our own practice is rejecting greater than 10. I believe we reject greater than 25. So, but wanted to call out at least what the Clin Micro Procedures Handbook states at looking at greater than 10 squamous epis. And then, looking for microorganisms, noting the staining characteristics, predominant shapes, large numbers of a single type, especially if associated with PMNs, it is potentially likely to indicate infection. Considerations there for specimens from neutropenic patients may have fewer PMNs if they're neutropenic. And observing for fungal elements. So is there fungal hyphae? Because actinomyces and nocardia, they may only be detected on low power due to low numbers and aggregation. So not fungal hyphae, but worth noting those two separately as well. So again, just things you're looking for from the microorganism standpoint when you're doing that assessment. And the next step being reporting. Do you use a few, moderate, many, 1 plus, 2 plus, 3 plus, 4 plus? How does that correlate back to the actual quantitative elements that you're reporting, 0 to 1, 2 to 3, 3 to 5, 5 to 10, so on and so forth. But special considerations here, accuracy is highly dependent on training and skill of the microscopist. So again, looking at PM shift, night shift versus your general microbiology staff. Reporting a normoflora in a gram stain. There is not a lot of guidance, again, from Clin Micro on this, so it's really going to be based upon local policy determination.
We have a question here.
Oh, yeah.
I'm sorry to interrupt.
No, go ahead.
When you have a neutropenic patient that might have less PMNs, do you change your grading scale?
I'll be honest, I don't know that we know when we have a neutropenic patient up
Okay.
front. Unless it's somewhere visible in the EMR, but I would say in our practice, it's not common knowledge for us to know if it's a neutropenic patient. But that would be interesting if you had that information. Could you potentially adjust your scale accordingly? Possibly. I don't know if anybody is. I think it's a great question, great call out, consideration for that. At this point in time, functionality does not exist. That's what IT would say. So ultimately, the most important role of the Gram stain is as a determinant of specimen acceptability, right? And yeah, back to what Dr. Novicki said, it is the kind of the de facto motto of the laboratory is garbage in, garbage out. So, kind of an interesting question here. What percentage of sputum specimens exhibit a predominant bacterial morphology? I got 58, all right. Yep, it was A. According to the literature, only 10 to 20% of sputum specimens are going to exhibit a predominant bacterial morphology. So again, it's not about the Gram stain, and I'm sorry, this is actually associated with the Gram stain. I think the culture potentially as well, but yeah, I mean, the low diagnostic yield of a lower respiratory tract culture, so that the importance and relevance of the Gram stain in determining what you're accepting. So I'm going to pass it over to Tim at this point. Wait, no, this is mine yet, isn't it?
It's yours.
Yeah, okay. Utility of Gram stain. 14% of adequate specimens had a predominant morphotype. Again, yield of strep pneumoniae from culture is only about 40 to 50%. And a positive Gram stain correlates well with a positive culture, right? What you're seeing in the Gram stain is you should expect to see in culture. And one of the other benefits, potentially of a Gram stain is it can discover less common pathogens when you're looking at those morphotypes. The last question I had for my clickers, I think, before I turn it over to Tim, looking for, if you can all see this, looking for feedback from the group, how would you report it? And this is a Gram stain of a sputum specimen. Polling is open. And many gram-neg rods, few normoflora, many gram-neg rods, few gram-pos cocci, few budding yeast, many mixed normoflora or many GNRs, few gram-positive rods, few gram-positive cocci. And there is, I'm not going to say that there's a right or wrong answer here. This was just a temperature of the room to see how people are reporting if they're grouping things. So, kind of an even split. A number of people said many GNRs with few normoflora, and the most responses had many GNRs, few gram-pos cocci, and few budding yeast. So again, I wouldn't say there's specifically a right or wrong. In our practice, I tend to push towards trying to group together organisms that are normoflora on the basis that if we report it, they may treat it. So again, ASM's Clin Microprocedure Handbook doesn't take a stance on grouping things together in the Gram stain for a sputum, but I was just kind of curious to see what people are doing. All right, what's next? Tim. Tim's up.
I haven't even started yet, but thank you. All right, so what's next? Thanks, Tyler, for putting all that stuff together. So my first question to you guys is, I didn't get the slide in here, but this is at the bequest of some of my staff members. And normally lower respiratory tract specimen, we think of a sputum specimen. So my first question to you guys is, pay attention. What is your favorite description of a sputum specimen? And I'll turn on the polling. I think I'll turn on the polling. Is it A, sputes, B, sputy, C, goober, D, which was a new one to me, expecto rejecto, or E, other? I think that's the fastest questions have been answered so far today. Do I have to hit A again? B. Just B? And looks like goober for the good ones and expecto rejecto for the bad ones. Thank you. Okay, so as Tyler had said before, I do not consider myself an expert in this. You know, I'm a working microbiologist, but definitely not an expert in lower respiratory tract specimens. So some of the things that just, you know, I want to let you know where I got some of the information from, and things that might be resources from you is the Infectious Disease Society of America, along with the American Thoracic Society, came out with new guidelines in 2019 regarding diagnosis and treatment of community-acquired pneumonia, and then Tyler had referenced multiple times, and I think Eric did this morning, the ASM came out with a new clinical microbiology procedure handbook last May, and this is the 5th edition. So, the usual suspects in community-acquired pneumonia. Oh wait, who are those guys? I guess this brings me to my second non-microbiology related question, but in the 1995 movie, The Usual Suspects, which character here was finally identified as the Kaiser Sose, the mastermind behind the crimes? Was it Kevin, McManus, Fenster, Keaton, or Verbal? Oops. This is just testing your knowledge of mid-90s theatrical trivia. So I'm assuming that half the people in this room never saw the movie. Quite the mix. But it did indeed turn out to be Verbal. All right, moving on with the show. The usual suspects really are the community-acquired pneumonia, and Tyler touched on this before. You know, these are the things that we all know, we've learned in school, and we've seen in the laboratory forever. The challenge behind some of this, I think, is a lot of these can be part of the normal upper respiratory tract as well, so that is why the specimen quality is so important. I'm not going to do this one to a clicker, but the IDSA guidelines include recommendations to routinely perform diagnostic testing, including cultures on patients with community-acquired pneumonia. I'll let you guys think of that in your head. I'm not going to open up the questioning on this, but the answer is it's false. They do not routinely recommend doing cultures or any other diagnostic testing for patients that are being managed in an outpatient situation. Okay, this does change if the patients become hospitalized or have severe disease. And I think Tyler did this one already in kind of regards to gram stains, but you know, what percentage of low respiratory tract cultures do not identify a pathogen? Super low recovery. And again, it has a lot to do with the quality of the specimen, the fastidiousness of the organisms that we're culturing for. So really the ISDA guidelines are really to manage these empirically. Radiology may help with diagnosis, and then always look towards viral pathogens as well. So I think that this is kind of the same scenario we had with urine cultures, is once we get into the laboratory, these guidelines are not necessarily for the laboratory. These guidelines are for the providers who may or most likely may not adhere to them, so we get all sorts of stuff in the laboratory. So what do we do with these samples once we get them in the lab? Skip that. Well, I guess we won't skip those. So when should we culture? As I mentioned before, if you get someone that's hospitalized, has a severe case. New to the guidelines this year were patients that were being treated for MRSA or Pseudomonas should consider doing diagnostic testing on, or patients that have been previously infected with MRA or Pseudomonas. The other one is if patients were previously hospitalized and potentially have that healthcare-associated pneumonia. So really, why don't we do routine culture? There's just lack of evidence for better outcomes in patients where we do routine culture when they're being managed in an outpatient setting versus actually, and treating them empirically versus actually doing the culture. Other diagnostic tests, blood cultures, Legionella urine antigens, strep pneumo urine antigens, influenza testing, those are all kind of based on the same thing, that you really only need to do those in certain situations when they're severe cases. So, back to my original statement of what do we do once we get him into the laboratory. And I'm not going to harp over these because these are all things that should be embedded in our brains from either school or our procedures or our competencies or countless other things. But the ASM Procedures Handbook kind of lays out what we should report, when we should report it, and in what amounts. So a list of things that we should report out in any amount listed here. A couple other ones that we should always report, but we shouldn't really look too hard for them. Strep pneumo and Haemophilus, if we find them, we should report them, specifically if they're associated with the way that the morphologies are seen in the gram stain. Another category is report if it's in significant amounts, even if it's not the predominating organism, and they define significant amounts in a qualitative culture as either being 3+ growth or, I guess, moderate growth, or something that's 90% pure, or for those that do quantitative cultures in BALs, 10 to the 4th or 10 to the 3rd for protected brush cultures. And then significant amounts in the predominating organism. So we really kind of have 4 groups here that we're looking at, and the list of organisms there too that we would look for. As Tyler mentioned with the gram stain, there are some things that we should include in normal flora, and these are the things that are going to be the upper respiratory tract organisms. I am certainly not going to read through every single one of those, but again, it makes some sense in the reporting of the cultures to list the things that are potential pathogens and not give providers information that may be misleading or lead to additional treatment that's not needed. All right, just some changes between the 4th and 5th edition of the Procedures Handbook. Neisseria meningitidis was previously listed as a report if it's in significant amounts, even if it's not predominating. In the new edition, it is listed as only reported if it's significant and predominating. Staph aureus is just the completely opposite. So now it's reporting if it's significant, even if it's not predominating. And pseudo Stenotrophomonas, Acinetobacter, and Burkholderia. There used to be a designation in the handbook for reporting those only on inpatients. That designation has been removed, so we'd be looking for those on all patients. All right, cystic fibrosis patients. Unluckily in my career, or at least currently, I don't have a large population of cystic fibrosis patients. As you guys all know, it's a chronic disease, and it just adds a lot of mucus to the airways. And that mucus is a great breeding ground for bacteria. Some differences, and I would take feedback if there's anyone here from Children's or potentially other sites that might deal with these more. But as Tyler alluded to before, we are not going to reject samples on these. The other recommendation was to only collect 1 sample per month on these patients unless there are special circumstances. And as far as culture processing, because Staph aureus and Burkholderia cepacia become a little bit more important in these patients, you might want to consider adding additional media to look specifically for those organisms. Again, they have the ASM manual or the procedures manual has a specific section on cystic fibrosis that has the multiple categories on what you should report, when you should report it, and in what quantities. So, like I said, I'll ask for feedback on this one. Is there anybody that consistently works up cystic fibrosis patient cultures? Children's? You guys want to make any comments on them, the difficulty of them, what you do with them?
So we add extra media like the mantile salt agar, cepacia, to recover any pseudo. So basically, any Staph aureus, whether it's rare or not, we work it up. Yeah, basically everything you have listed is what we have as our guidelines. So non-lactose fermenters, depending on the quantity, we'll work it up or we may not work it up. So we actually have clinics for cystic fibrosis, so we get like a lot of them in like once a month roughly. So everything you have listed is exactly what we go for mounts and whatnot.
What's your record for the number of isolates you've reported out on one of those?
I want to say my record has been about 7 or 8 at one time. We have a lot of restreaks for cystic patients. So just because there's so many things we have to work up in them, and a lot of it isn't necessarily mixed flora.
Okay. All right. Thank you.
Yeah.
Okay. Perfect. Eric?
Can you clarify your definition of significant, especially when it sits right next to the word predominant? Or are those terms synonymous in your mind?
Well, actually, in the new handbook, they are synonymous for the cystic fibrosis patients. It says predominant or significant growth, and they don't have different definitions for them. So. Okay, I wanted to talk a little bit about quantitative cultures for BAL samples. That is another diagnostic technique that could be used to try to differentiate what are organisms actually causing an infection versus just normal flora type things. Setup is 2 different options. You can either do a serial dilution on these cultures, on these samples, or there are procedures for just using a calibrated loop similar to a urine culture. The reporting then gets reported out quantitatively, and there are different thresholds that would delineate the organisms versus pathogens versus oral flora, okay? As I said before, it's 10 to the 4th for BALs and 10 to the 3rd for protected brushes. Clinical utility of the quantitative cultures, and I would be looking for some feedback on this too from anybody who does these. I did find one article, or I found several articles, but one of them, a lot of them had to do with ventilator-associated pneumonias. And this particular one was a point counterpoint type article. And some of the pros that they listed for these was you can do a more antibiotic modifications or de-escalations, basically by finding out that a patient doesn't meet the threshold or the colony count doesn't meet a threshold, and they can deem that it's not a pneumonia and de-escalate. Potential to identify slower growing pathogens. They didn't really expand on this one, but I'm making the assumption here that as you're diluting that out and diluting out the normal flora, you might be able to see some of those slower growing pathogens better. And then again, with the de-escalation is being able to rule out a pneumonia. The cons to it, some of the studies showed that there's really no significant difference in clinical outcomes. And again, this was based on ventilator-associated pneumonias, so things like the number of days on the vents, the length of stay in ICU, and antibiotic usage. You know, when they compared semi-quantitative cultures to quantitative cultures, they didn't see a difference in those metrics. The other con is that there is pre-analytical variables, as there is in everything, but if you think about a bronch specimen and the ones that you guys get in the lab, sometimes they have a little bit of fluid in them, sometimes they have a lot of fluid in them, so there might be a predetermined dilution factor there. And then it does add some complexity to the processing and the interpretation because you have to obviously do the dilution and then do the colony counts. You know, so in general, the articles that I read on it was there was really no consensus if quantitative cultures are better than semi-quantitative cultures, in particular as it associates to VAP specimens, but I did see some information too for community-acquired pneumonias as well. So I guess one of my questions on this, again, for audience participation, are there labs out there doing the quantitative cultures? I see Tom shaking his head because we've had some of this discussion before. Do you have any comments on it, how your providers utilize it? Do you think it's useful? How long have you been doing them?
So yeah, we have done them forever, and you know, I haven't looked at that literature in quite a while, so I don't know, you know, what the populations it was shown to be effective, but I think, you know, I kind of think of it as in the same way as, you know, reason why we do a quantitative urine culture is because there was a correlation made, you know, with these opportunistic pathogens that, you know, are colonizing as well. is that above that threshold, they're likely to be a significant, there was a good correlation with the pneumonia.
Right.
There's downsides to the bronching process itself. Are they hitting the right spot and all that? But my recollection was there was, data to support it. But like you say, I don't remember what the populations were. Maybe someone else remembers. A ventilator. I mean, they do it on, the seriously ill patients, probably our VAP patients.
Do you change the organisms that you would report, or are you still reporting just the potential pathogens? Like, say, if you would get a Viridans group strep that was, hit the quantity for significant.
Again, you could kind of get me in a spot here because I haven't looked at this stuff in a long time, but I think it's, specific, opportunistic pathogens. So it's got to be above the threshold. I don't know, can anybody confirm that? But my recollection is that, it has to be an opportunistic pathogen that might be involved, your, strep pneumos, H flus, Moraxellas.
Okay.
And above the break point. And then the other stuff, no.
Okay. That would just be lumped in as normal flora then, or?
Yeah, pretty
Or-
much,
okay.
yeah.
Okay.
Others?
Thanks for your input. I didn't mean to put you on the spot. I just know that we had.
No. I just,
I don't know how many laboratories are doing this. Is anybody, just by show of hands, is anybody else performing quantitative bronchs? So there's quite a few people. Okay. All right, cool. But nobody else wants to talk. All right, quick trivia break to refresh. And this, as I was putting this together, it was when the Brewers were first starting. I always thought when Eric Munson does his things, he always does the "you make the call." It got me thinking about baseball, and in memory of one of my former colleagues who was a big Brewers fan, who unfortunately we lost earlier this year, I thought I'd throw this in there. So this year, the Brewers started the season with a 4-game winning streak. What is the longest winning streak in Brewers history to start a season? 4, 7, 9, or 13?
Hey, Tim.
What did
I think
do?
you have the previous clicker thing up. You might have to restart it.
Oh, dang. I don't know how to do that. I think I ruined it. Oh, wait, I lost power. Sorry about that. Thank you. All right, let's try this again. Okay. Stop it. View it. All right, so the predominating answer here is either C or D. So the correct answer is, in 2013, 2014, they started the year with 9 games, but in 1987, they won 13, and there's the real Brewer fans. All right, I wanted to touch base a little bit too on molecular testing and multiplex panels, because we talk about new technology coming out. What else is there other than traditional culture that can help out? So we've all, I'm going to skip a couple here, but this was a published from a couple years ago that listed out kind of all the different options for multiplex testing for lower respiratory tract specimens, and you can see there's a wide variety. They include viruses, they include bacteria. And the question is what is really the significance of these and what's the usefulness of these? In this particular study or paper, they actually referenced a different study that was done that they had seen a 63% increase of specimens reported as positive when they did a multiplex panel as compared to routine diagnostic techniques. And they also saw that they could potentially adjust antibiotics in about 70% of patients. So it could have some impact. Some pros and cons to them, and this is more in regards to some viral panels. And when you look at viral panels in particular compared to traditional viral technology, which is a cell culture. Definitely if you're using molecular, you're going to get a reduced time to result, reduced length of hospital stay because you're getting that result a lot quicker. Might isolate the patient more quickly or de-isolate them more quickly. And you'll have a reduction in antibiotic use because if you get a positive result from one of those viruses, the provider might click and say, hey, it's a viral pneumonia, we can take them off the antibiotics. Some of the cons are high patient charges, so especially if you're not doing that, if you're using these in an outpatient situation, patients could be charged upwards of $5,000-$6,000 for these. You might be able to detect colonized viruses. Up until I read an article just last week regarding pediatric patients, there is a certain about 30% of healthy pediatric patients can be colonized with certain respiratory viruses. Obviously, that varies depending on the virus, but there is some colonization potential there. And then the biggest con, again, is positive results might not affect patient management, okay? And that comes down to this, and this is a particular viral panel that this author was utilizing. And what they found was through all the things that are on there, there's only 2 that potentially would have changed clinical management, and that's influenza A and influenza B. So the question on some of these is it worthwhile to do them to get that result? And obviously these aren't questions that the laboratory can make for them, but we can maybe help direct providers in ordering them in the right circumstances. As I mentioned before, if they're cost effective, that could be a pro, that could be a con. A pro if you're getting them out of isolation, reducing antibiotics. A con, particularly because they can be expensive laboratory tests to run. And if you're in a situation where they're working on inpatients and you get paid based off a diagnosis or a DRG, high laboratory costs might not be cost effective for the facility or particularly the laboratory. Moving on to some things that are less frequent, and I know we're probably running out of time, but I know we wanted to touch a little bit on pneumocystis, and pneumocystis, diagnosis of pneumocystis pneumonia. Just some background on it. Originally classified as a protozoa, reclassified as a fungus in 1988. What was interesting to me is that most healthy children are exposed by age 4 because it can be found in the environment and can be easily passed. First really appeared during World War II, and then it became widespread and well known during the HIV epidemic in the 1980s. More recently, it is becoming increasingly found in non-HIV patients as we have more chemotherapies, more immunosuppression therapies and things like that on patients. We're going to see there's going to be more patients that are susceptible to it. Significance is it does have a relatively high mortality rate, upwards of 80% in HIV patients, anywhere between 40 and 70 in non-HIV patients. Diagnosis samples, lower respiratory tract samples, induced sputums, and induced sputums based on the literature are better samples than just regular expectorated sputums. Bronch specimens, potentially oral washings, NP aspirates, blood serum, and urine as we look towards diagnostics to the future. So the historical way to diagnose this is through a stain, and that can either be a fluorescent stain or a traditional stain like a silver stain or a Wright stain. The really good thing, and these are some examples of it with the classic honeycomb type look to them. The good thing about the stains is a positive result does confirm diagnosis. The unfortunate thing about them is the negative result does not rule out the presence of it, just because it can be hard to detect and it's relying upon sample quality, reader competency, and all the other things that go along with microscopy. Immunofluorescent staining might be a little bit easier to read. The procedure for this is a little more intense because it is a fluorescent stain as far as the timing. It does have a little bit higher sensitivity than your traditional stains, and it is easier to perform, at least interpret, underneath the microscope because you do get the fluorescence. They kind of jump right out at you. Again, you see the same honeycomb type shape structures of the cells, and that is the diagnostic piece of it. Again, just like any other microscopic thing, it is really dependent upon the acumen of the reader to be able to first notice these, rule out what's the difference between maybe nonspecific fluorescence and the actual organism, and make that positive result. Other things that are coming into play now are some molecular methods, have both high sensitivity and high specificity. Some isothermal amplification methods might be a little bit easier and not as labor intensive. They're looking at flow cytometry, antibody assays that you might be able to find in the urine or the blood, or actual blood antigens. Some of these are not fully available at this point from what my understanding is, but they might be things in the future to increase the ability to diagnose this particular pneumonia. Is there anyone that's doing molecular methods for pneumocystis? Everyone is traditional stain. Is anybody doing these stains within their microbiology department as opposed to their pathologist doing them? Microbiology? Okay. Fluorescence or, okay.
Yeah, we used to do the fluorescent stain in-house. We stopped that, I want to say sometime around 2019, 2020, and we now send it out for molecular to a referral lab. But when we did do it in-house, is St. Vincent's here? Yeah, the St. Vincent's was always kind enough to share positive controls with us, because that is one of the problems related with this assay for fluorescence was always finding a positive control, because there really wasn't anything out there from a vendor perspective. So we always shared positive controls with St. Vincent, so we were appreciative of that. But I would say even with that, yeah, that the stain could be difficult to interpret even with a positive control.
Okay, cool. Thank you. All right, one last trivia time before I turn it back over to Tyler. Sorry, and it's more Brewers trivia. Did I stop it last time? I did. All right. Prior to moving to what was then called Miller Park in 2003, where did the Brewers play? City Stadium, County Stadium, Athletic Field, or Valley Park? And B, County Stadium is the correct answer. So you guys clearly know your Brewers trivia, at least their home stadiums, better than you do your 1995 movie trivia. All right, I'm going to hand it back over to Tyler. He's going to touch a little bit more on some of the things we isolate less frequently.
All right. I think we got about 10 minutes or so. So we'll try and do this in a timely manner. There's a number of different core pathogens, opportunistics, and really what falls into the common indigenous flora. And there's workup criteria, the whole significant predominance, those things that go into it. So just kind of breaking them down into the tables for depiction here, and then just highlighting those couple that we're going to try and touch on with the time we have remaining. So Francisella tularensis, we don't see a lot of this within Wisconsin, but there is, I want to say CDC reports around 3 to 5 cases a year. So we got to talk about it, because that may be you. So infection route, it's zoonotic exposure, tick and deer fly bites, which I wasn't super familiar with. I always think of rabbits and, prairie dogs, muskrats, that type of thing, but that is where exposure process occurs, and also dust and aerosol exposure can occur as well, which causes a pneumonic tularemia, which is the most serious form. So looking at kind of an identification guide, really kind of calling out the scant growth on a blood auger plate and no growth on a McConkey plate. With the slow growing gray and white on chocolate. So when I think about the bioterrorism exercises that are sent out, that scant growth, slow growth is always a key one of the key attributes that we want to highlight and bring that awareness to the microbiologist at the bench, because they may be working with open plates and highlighting if they're seeing that kind of growth. So other identification guide features there you can kind of see, and ultimately you're not going to be performing a sensitivity on this bug. You're going to be following your LRN reporting guidelines, and that is actually a hyperlink to the LRN reporting guidelines that we include there, but just a picture of it, and again, just kind of highlighting some of the growth characteristics there and when you would report it. Moving on to nocardia, more common amongst somebody with a weak immune system, so some depiction there of the different things that might cause or are associated with a weak immune system. You're generally seeing this as an environmental transmission in terms of mode of transmission, so standing water, decaying plants and soil, with that exposure occurring through inhalation of that decaying material, a cut or a scrape, and contaminated medical equipment or post-surgical. So most often it is a lung infection, though there are other types of infection that can occur with nocardia, but because we're talking about lower respiratory tract, we're focusing on lung. But yeah, I mean, notable because it can spread to other parts of the body, including the brain, which is a very serious complication, with 44% of those being lethal. So for nocardia, on a routine lower respiratory tract culture, you're not including specific media in your process for a lower respiratory tract culture. But if you come across it, whether in the gram stain, you are going to be looking to report that. And if it's suspected, but the provider ideally is going to notify the lab, but in practice, I'm sure that doesn't happen too often because it doesn't with us. Some symptoms there, consistent symptoms, or symptoms are consistent with tuberculosis. Community-acquired pneumonia, which kind of complicates that picture because we don't routinely set up media specifically for it. Fungal pneumonia and lung cancer. So looking at our identification guide, branching variable gram-positive bacilli, it can be seen in a gram stain. When you're looking at it on media plate, it's the dry adherent colony, chalky. There's actually a number of colonial colors that it can't display. And ideally, that's going to be your trigger between the gram stain. If you can go right from the direct specimen, if you do see that branching variable gram-positive bacilli, to go to a modified acid-fast, or if nothing else, at least if you are seeing something like that in culture. Figure 1, figure 2, just kind of depicting for nocardia, what you can see. Sometimes it gives this beaded appearance, like a thicker, sporadic beaded appearance can occur with that modified acid-fast. But if you're identifying nocardia in lower respiratory tract culture, you may be sending it out for sensitivity if it's requested, but you are going to be reporting any amount that is present. And I have up there hold plates for 7 days because that happens to be our local practice, but that may not fit yours. Yeasts and molds may represent normal oral flora. So Candida species being one of those bugs that is very representative of normal oral flora. Those that may represent common environmental saprophytes or serious infections. So you have Cryptococcus, Aspergillus, and Zygomycetes. And then those generally associated with infection, you're thinking about the dimorphic fungi, Coccidioides, Blasto, Histo. So, clicker question here. If a yeast is the predominant organism in a sputum specimen and no other obvious pathogens were present, we're talking about culture, remember, would you, A, ignore it and ignore it as part of normal flora, B, rule out Cryptococcus and then ignore it, C, rule out Cryptococcus and report generically, such as yeast not Cryptococcus, D, identify it and report out to at least a genus, or E, identify it, is there an E? There's an E. Identify it to species and perform AST. All right. Predominantly, rule out Cryptococcus and report generically. as yeast not Cryptococcus. Some have identified or have selected identify it and report to at least a genus level. All right. So for yeasts, common respiratory yeasts you may encounter, Candida species very obviously, Cryptococcus neoformans potentially less frequently, most probably less frequently than Candida, and the dimorphic fungi. So just highlighting here some of the chromogenic media that's available that you can use for identifying some of the yeast species down to at least genus level based on that pigment production that they may produce. And this is just a picture of yeast being present in a blood culture specimen. So our identification guide for Candida species, the medium size, creamy, may exhibit poor growth on McConkey, catalase positive, which is not truly a true catalase positive, but it'll give that reaction. If you perform a calcifluor white KOH stain, that'll help give that picture of a yeast species. It is urease negative, so if you use that for part of your Rouleau process, and potentially there it's instrument ID if indicated. So there is not really a sensitivity to be performed on this routinely, and really for Candida species, let me just turn that off. Generally, you're not going to report the other yeast unless directed by ID. And the reasoning for this is Candida are not a cause of pneumonia, except possibly in oncology or lung transplant patients. And even in those instances, it's not, the literature is very weak to support that there is actually a Candida pneumonia occurrence. So really there, going back to the kind of that clicker question of how you're going to report, you really are ruling out the Cryptococcus and kind of going to a generic yeast, not Cryptococcus, because of this statement here of not a cause of pneumonia except in some of those possible cases, and even then it's very weak. So again, Candida being part of the normal flora, and it is worth noting there are some circumstances where ID may actually, or infection prevention, it might be necessary to rule out Candida auris, which is obviously an upcoming emergent pathogen. Cryptococcus neoformans, so again, yeast colonies performing potentially a calcifluor white. It is urease positive. So if we go back to that Rouleau guide here, most other Candida species are urease negative. So this, for Cryptococcus neoformans being urease positive, that's a good trigger for you to then perform full ID, which is what we are doing in our institution if we run into an organism like that. In terms of reporting, in the case of Candida, you're really not reporting it routinely, kind of doing that Cryptococcus or yeast, not Cryptococcus type report. But in the case of Cryptococcus neoformans, you are going to report any amount. So associations with pigeon droppings, pneumonia, meningitis, disseminated disease, and most important, in immunocompromised patients. Molds. Common molds you may encounter. There's environmental saprophytes such as Aspergillus, the dimorphics that we already, blastomycosis, zygomycetes such as rhizopus. So with the exception of dimorphs, primarily these molds are an issue with the immunocompromised patient population. They can be contaminants or they can be life-threatening. So there's kind of a wide range of do you or do you not need to report it. So looking at molds, if you're seeing something in a gram stain, it is a good indication to add some fungal media. Not to be confused with yeast, with pseudohyphae. That can be something that can trip up some of the newer microbiologists or those who are infrequently performing gram stains or calcifluor white stains. And again, you can use a calcifluor white. If you see something in a gram stain, such as this picture here, you can always move to a calcifluor white to help you determine what this is. Anybody want to shout out what this is? It's blasto. This was blasto on a patient we had. So we had it initially in the gram stain. Fungal media or fungal culture was not ordered. We had moved to doing a calcifluor white, and at that point we were able to contact authorize and provide or get a fungal culture order added on and proceed from that point. So in terms of identification guide, generally for molds, it's going to be a dry, fluffy colony. Again, the gram stain is going to kind of help display that. You want to be working these up, obviously, in a BSC level 2. So anytime you're working with something that looks dry, fluffy like that, best practice, getting it underneath the hood to prevent any exposure to yourself and to your fellow microbiologist or whoever else is in the lab with you. Doing that calcifluor white, or possibly a lactophenyl cotton blue if you have that. And then, making sure to tape those plates, because it's most likely it's going to land back in that incubator and be part of potentially your routine cultures, because this is from bacterial media that we're doing this. So if you're encountering this on bacterial media, you do want to call that out. But it's going to be kind of up to your institution's practice of whether or not you actually want to work that up, depending on, again, you could have that range of environmental contaminant all the way to potentially lethal. Aspergillus, again, this is it can be a common environmental mold, but it can also cause aspergilloma, which is that fungus ball down in the lungs, and allergic bronchopulmonary aspergillosis. So you see that in asthmatic patients and cystic fibrosis patients, and invasive pulmonary aspergillosis. So those with a weak immune system or healed cavitary lesions. So just depicting here, obviously, colonial growth compared to lactophenyl cotton blue of Aspergillus species. And the zygomycetes. So again, another common environmental mold, but it can be implicated in immunocompromised patients, and it can be very difficult to treat, often with surgical intervention being required. There is a call to actually report this on any level if you do see it, because it can rapidly disseminate and cause some downstream sequelae quite quickly. If you see how fast it grows on a chocolate auger here, this was how fast it's growing. I think this was after 1 day, not in routine fungal incubation conditions and not on routine fungal media. This is on bacterial media, bacterial incubation conditions, and how fast it starts growing. The same thing can happen, to the patient that this infects, which is why it is one of those common environmental molds that you actually are going to report in any level if you do encounter it, because of that potential implication. That really pretty much wraps it up for myself and Tim. I guess we'll take questions. Yes, I see a question there.
I was just wondering if people, or how they're incorporating we're starting the BioFire panel, how they're incorporating it with their culture, if it's replacing it, or if you're doing both.
Like specifically the lower respiratory
Yes.
pneumonia panel, I think it is, correct? Yeah, I guess we don't perform it at our institution. We did work it up. I guess I would say comparatively to culture, it matched pretty well with culture. There were some things we found on the lower respiratory panel, the multiplex lower respiratory panel, that helped guide culture workup, but ultimately it doesn't preclude the need for culture, because so much of what we find in culture we end up going down the road of doing susceptibility testing for, that you're still going to have to do culture, especially depending on what you run into. So Haemophilus influenza, if you're going to do disc diffusion susceptibility testing, Pseudomonas aeruginosa, same thing. So you're still driving towards that antimicrobial susceptibility test result. So I think there's a place for it, but potentially in a restricted setting. I don't know if anybody else has comments about that, Tim, potentially here.
I was just going to ask the follow-up question. If there's anybody out there, so I don't do that in my laboratory either. We use our reference laboratory for that. And what we see utilize it for is a lot of like secondary. If a patient has they'll have a negative influenza, RSV, COVID, and then we'll get the request later for an extended panel. I guess my question is to anybody out there: is there anybody who has absolutely done away much in the same way that you might have done with the stool culture when the syndromic panels came out? Is there anyone who's actually done away with either viral culture or routine bacterial culture in lieu of using a multiplex panel? And a lot of head shaking no. Okay, thanks.
Just a quick question on our BALs. We get a lot of them now with our new pneumonologists. We didn't used to get them hardly at all. But my question is, if you have a high percentage of your BALs that have, like 3 to 5 colonies or 10 colonies of a yeast, like on 3 collections in the same person, or you get one colony of a mold here, one colony of another mold, it could be aspergillus, it could be demataceous fungus, whatever. What is the clinical significance of that, and how do doctors usually respond to those kind of reports? Because I'm just surprised we just see so many BALs with few amounts of like Candida. I do know we did have a problem with processing. Depending when you get a new pneumonologist, the way they collected their BLs and would put them in an ice bath with contaminated water, and we would get this consistent reddish hue, flat, non-hyphal forming colony on our BHI G-auger. But I don't know, besides a possible, collection methodology affecting that, how do doctors treat those kind of reports?
Yeah, I guess my take on it would be, clinically the patient, are they immunocompromised? If you're getting individual isolates of an aspergillus or something like that, I have seen that recently in an ICU patient we had where they did request us, our team, to work it up. We had identified on this patient, and with this was a HIV positive patient, and we had called out in the sputum culture, mold was present, contact us if further ID is warranted, and based on the patient's, clinical background, they did request us to identify it. We had identified an aspergillus. During medical rounds, in discussion on the floor, they had determined that it was not relevant. So even though they asked us to work it up and identify it, clinically, the significance was nil. That's just one anecdote, one experience. I'm sure there's a lot of variation there. I guess I would look to some of our fellow MD or PhDs in the audience. Ray, Tom, Eric. Anybody else I'm missing? Come on up. There's a microphone right next to you.
I would just mention for the yeast, and if they keep finding it, it's very common for BAL things to get contaminated as they're drawn out. And, yeast is a lower respiratory like Candida. Really it's a diagnosis of biopsy and things like that demonstrates that it's actually actively invading the tissue. So RID people, wouldn't think anything of yeast out of a BAL.
So that more or less kind of goes back to the yeast pneumonia just really not being something that's in literature has been proven on without histology essentially to show that there is invasive infection.
It's very, very rare.
Yeah.
So you wouldn't do an identification?
I wouldn't. I would just call it yeast, not Cryptococcus.
Thanks, Ray.
Not to delay break any farther, but there was a paper published in JCM 20 years ago probably where Joan Bernfanger in Springfield, Illinois, a pathologist, she changed how her techs reported out yeast, right? So in the past, before the study, it was an outcome study. So before the study, they did a full genus species identification, even Candida, out of a respiratory secretion. Then she changed it to not reporting yeast by genus species identification, just reporting yeast. And it actually changed administrations of fluconazole. Fluconazole usage went way down in their facility without any change in morbidity or mortality of the patient. Further complementing what Ray suggested in just reporting out a very generic identification of yeast, maybe a yeast not cryptococcus. So that's an outcome study in support of what was just mentioned before.
Thank you. Any other questions?
All right, then I want to thank Tyler and Tim, and thank you for bringing up the bioterrorism agent for me again, reminding people this is another source where you might see a Francisella, so thank you for that. At this point, let's give them a hand.